All right. Anyway, I want to thank everyone for coming today for our instructional seminar slash class slash IV, or I guess that's right. We have Andrew Schaffenacker, who is an alumni from WIU, and Nina Schaffenacker, who's also does things in the health career field, and she's going to tell you a little briefly about what she does. Andrew is a nurse. He actually had his degree in biology first, and we got to do some pretty cool things out at the field station. I really encourage students to take classes at the field station. Back then, I was kind of a rogue professor, so I take my boat out and we'd go boating, and I think they would kick me off my tube. They probably did all sorts of things that would irritate the Kibbe director anyway, off the record. But anyway, but it was a good time. Let's put it that way. And even my little son would be out there with us, and of course now he's taller than me. So Andrew, when were you here, by the way? And I don't know if you come in. Yeah, sure. Anita, of course.
So I graduated in 11. So I was probably here between, right there, make me do that. I think between 8 and 11, because I transferred in about halfway through.
Oh, wonderful.
Yep.
And so you took at least one field class with me, and I believe that was entomology.
Yep, I did entomology.
Did you take any other classes with me?
I did ornithology. I did ornithology out at Kibbe.
Yeah.
That was a good time.
With Dr. Pierre?
Yep, I did physiology with you.
Okay,
I think
this class that some of you are in.
you have to do your 500 level lab class.
Oh, that would have been the plant animal interaction.
Yeah,
class,
that one. That was
which,
cool.
Yeah, that was cool. Yeah, I think I will probably offer the plant animal this spring. Here's a couple of my lab students too. So, and then Nina, can you tell us a little about yourself?
So I'm the missus. I like to say I'm the better half. So I actually have experience in the medical field, not as a nurse. We actually met in the nursing program out in Springfield. Did not enjoy clinical, so I just went into medical scribing. At that time, I didn't know what I wanted to do in the medical field. However, that was a great opportunity to get like my foot in the door, to make relationships, and really kind of see a plethora of professionals kind of work together in one unit. So I was in the ER. So I have that background. I was a CNA, and so because I didn't like that, which was okay, I am now in clinical psych. So that's what I do.
Well, I'm going to go ahead and get out of your all's way. Andrew, I look forward to hearing how you moved into the nursing field as well. Yeah, it's a real pleasure having you out.
Yeah.
Thank you.
Yep.
Yeah.
All right, like Dr. said, my name's Andrew Schaffenacker, again, my wife Nina. So I'm a RN over at Memorial in Springfield. I'm currently in the cath lab. I've been in medicine for about 10 years now. That's where I go. Maybe technical difficulties. There it is. So yeah, 10 years total. It was 7 years ER and trauma, and then transition over to cath lab. Just want a little bit change of pace, a little bit better hours. Actually, I have my associate's degree in nursing from Lincoln Land over there. Got my, like Doc said, my bachelor's here for biology. Medicine, it's a great field to get in. I mean, you're definitely going to get in what you put out. Yeah.
We got it.
And yes, you get to help people, but there's no end to learning. I mean, they call it practice for a reason. Nobody's perfected it yet. And just the myriad of fields, like the two I've been in, I still don't. I know maybe just an iota fraction of what there is to learn. So again, if you guys are really interested in this type of stuff, most hospitals, I can definitely speak for Memorial, there's lots of like nurse internships or just internships of just about any, or shadowing positions at whatever level you're wanting to look into it. Nursing, doctors, all like radiology, respiratory, all of it.
PA, NP, all of that. Take that opportunity to job shadow, for sure.
Yeah. Even if you don't end up liking it, please try it out. Like, okay, yeah, well, no thanks. And like she did.
And it's okay if you don't like it. Like, trust me. I was like, no thanks. We're gonna do something else. It's totally fine, guys. I know there's like that pressure, like in college. What am I gonna do? What am I gonna do now? Man, I don't like this. I gotta change my degree. Like, we get it, but it's not the end of the world. It's just kind of, I think the takeaway for this, we both have changed our degrees multiple times to kind of figure out what we're wanting to do, right? And for my personal experience and for his too, we both really say, we say to our kids, like, go into something you're really interested in. It's gonna make the stress worth it. Of course, you know, the pay, you have to make your way up there, but definitely go into something you're interested for.
All right, so getting back more to like what this whole thing is about. So intravascular access, does anybody know what that is at all? Any clue?
Give you a hint. Say IV.
Hey, okay. What is it used for? Why is that important in a hospital setting? A lot of this is just going to be like hospital setting, not nursing home or anything. Why do we want that in a hospital? What's it for?
Yeah.
And please don't overthink it. It's a really easy answer.
Giving fluids.
Yeah.
Yeah.
Fluids. What else?
Fluids, yeah.
What else are we gonna do?
Draw blood.
Yep. Fluids, blood. What's other important thing that generally goes in the body?
Medication.
That's it.
Yeah.
Yep. Those are the main things. And I can guarantee anybody that comes in a hospital, they're gonna have an IV the entire time they're there. And if they rip it out, guess what? They get another one.
Protocols, guys,
Yeah.
protocols.
So we got lots of different types of access you can get into. The most common are the top two, which are the IVs and butterflies. IVs generally stay in the body. Butterflies, just kind of come in, get blood, get out, done. You can get to a little bit more of the higher difficulty, more long-term or oh crap versions of access. One's gonna be the IOs or interosseous needles. I'll show pictures of that. We'll explain more about those as when we get to it. Central lines or PICC lines, which PICC is peripherally inserted central catheter. Those can be basically they generally go in the arm, usually done by ultrasound, goes all the way up and then drops right into your heart. Central line, same type of idea, goes in the neck.
And this is true. You make our jobs so much easier if your hearts look like that, but you know, that's what ultrasounds are for too. You know, we have a hard time finding the vein.
So everybody's seen an IV, probably has a good idea of what it looks like. This is your basic one. This one particularly is an 18 gauge. There's a lot of different sizes, and it depends on what you need it for and the size of your patient or the size of the vessel you're going after. I brought a bunch of stuff. I'm going to be handing stuff out. Got a bunch of stuff for you guys to play with as well. Butterfly, again, super common. We've probably all seen one of these. This part, that's new. Obviously, it's gonna go on the bottom. The blood comes out right through there, goes into whatever tube you're filling, usually some of your lab tubes or vacuum sealed. So just there's no pulling, no drawing, nothing, just automatic goes right on in.
This is usually easiest.
Yeah.
Yeah.
No, don't get me wrong, IVs, all of these different types of things, the whole point of it's pretty much the same. It is a different skill set for each one, especially with the more advanced stuff. Butterflies are a little bit different than an IV. They're almost the same, but it's not always the exact same type of process. Some people are better with butterflies, some are better with IVs. This part here is actually nice. So when you're getting the blood out, you've got multiple tubes you're filling up. This will seal that needle. So when you're switching tubes out, you're not just spewing the patient's blood all over you, all over the room, or anything else. So then we have the central lines. So these are the ones that are generally going to be going, these are ultrasound guided, goes in your internal jugular. As you can see in the picture here, just drops boom, right into the right atrium. Real quick, that's going to be mainly for like ICU type patients, like the super sick people. They're in the hospital setting. These are generally, they can last longer than an IV. IVs, they generally want to switch them out every 2 to 3 days, just because infection, phlebitis, all that good stuff. You don't want to just leave that in there long term. These are a lot more long term. These can last up to about 30 days before they want to start worrying about maybe changing them out. And the good thing, this was called triple lumen. So you got 3 different ports. These 2 generally are going to be reserved for medications. The red one there, that try to make that easy, that's good for blood draws. Red blood makes sense, right? Also, these type of lines, the same with the PICC lines, it's going to be reserved for medications that are they're really harsh on blood vessels, especially smaller ones that are going to be in your arm. So they want to put that right in that big monster IJ. It's a big vessel. You put medication in there, it's not going to mess with it at all. So that's generally what they reserve these for. And then the next step, this is going to be for even longer term, it's going to be the PICC lines. This takes a lot of special training to do. These are also ultrasound guided, generally going in the brachial vein. These are going to be real long-term, these can last a couple of months. This is gonna be for people receiving like chronic IV antibiotics, chemo, that type of stuff. Yeah, the main issue with both these and the central lines that you have to watch out for is they get infected so easily. Because most of the time, the patients, especially when they take these home, because they can go home with PICC lines. Central lines, no. But the PICC lines, the patients don't necessarily always take care of them correctly, so it's very, very easy for them to get infected. And we generally try to put special alcohol caps on them to help prevent that, but even the insertion site, they're not cleaning it right, or they get it wet. There's just a myriad of issues that can go on with these. So if they can, or if the patients are going to be going home with this, they really try to make sure that they give them lots of education on how to properly manage and take care of these things. And every time they come back into the hospital for their infusions, they're always being monitored, always being documented, checked on, make sure you're okay. Is it still doing okay? Is it flushing good, pulling back good? No signs of infection. All right, cool. If these do get infected, generally just take them out, switch the arm, put a new one in. Now the scary one, the IO needle or interosseous gun. So this is the most common one you're going to see in healthcare. They are going to be reserved primarily for the ER. Some ICUs do carry them. So this guy, that is the, oh no, this person's really not doing good. And we can't get an IV on him, but we need one like right now.
So where do you guys think that this one goes?
This guy here,
In
where
the
does that
body?
go?
Where do you think?
Interosseous, what does that mean?
We can't find a vein. So where do we go next?
Any thoughts? I mean, yeah,
Oh, nice.
right in the bone.
Yeah.
Primarily for adults, it's gonna be right there, right in the tibia, just south of the knee. You find that flat spot of your shin,
Yeah.
going right in there.
I had a patient one time, he was a burn victim. I'm not gonna go in the backstory, so 89% of his body is burned, so we can't find a vein. So it's my first time actually seeing this, and I'll tell you what, I don't want to ever see that again. It is incredibly painful. I don't think we got him out in time, but he needed medicine, right? Because we were going to transfer him. But yeah, it does go in the bone.
So the things with these, I've done probably a couple dozen of these for various people. You got the different sizes right here, depending on size of the patient. Pediatric. Ever hope you ever have to use that. The 25 millimeter, that's gonna be your general, regular everyday adult. 45 is gonna be if the person's a little bit larger, a little bit more like adipose tissue you're trying to get through. So all you do is hook this bad boy up to the little gun right up here. So it's actually a drill. Press down and pull the trigger, and it just sucks it right on down. Take it off, and boom, you have an instant central catheter, and it does go right into the bone marrow. So in my personal experience for doing these on people, thankfully the very few that have been awake, because generally most time these are for patients who are coding, they don't know what's going on. It's not the insertion that hurts. They say, ow, that sucks for a second. Okay. However, with most IVs, you have to flush them through, make sure you got good blood return, put it back in. That's the part that hurts. When you push that fluid through, you're expanding out that bone marrow. And the one experience I can remember is a gentleman who was on our trauma table, and he was kind of with it. He was very slowly exsanguinating, bleeding out. We put that in, and he was really lethargic, just groggy, right? Put that in, flush it through. That dude sat up, bolt upright, started screaming, started swinging. It woke him up real fast. And because of that, the intense amount of pain, generally we're mixed lidocaine into that numbing medicine, put that into our fluid, flush that through. Still sucks, just not as bad. So, and this other horrifying monster, that's called a fast one. I put that up just because I think it's interesting. That's military grade. So that bad boy goes right here. So I've done a few military combat casualty courses just for fun. They had us use one of these, obviously on a dummy, and like it's oh crap, this person's bleeding out. We need to get stuff in them. Basically, taking your hand right in the chest, and you have that many lumens or needles of access, routes of access going right in.
Hey, Andrew,
Yes, sir.
would you do the same, they use something similar for like the one on the left for bone marrow? Like if they need
Like a biopsy?
biopsy?
I don't believe so because I don't think you're able to get out what you're aiming for with the bone marrow with that. I don't know if that needle, it's rated to be able to accurately draw that
Cause
stuff
I
out.
did do a bone marrow when I had cancer. And so they gave me some medicine, said, you're not gonna remember this, and everybody's dogpiling. And then,
Yeah, you're not gonna remember, but here, let us mob you first.
Okay.
Yeah, it hurts.
so anyway, I don't remember. I just remember that part of then.
That's
I
right.
don't remember the rest of the people don't know.
Bear hug.
Yeah, cause I got that to you and you kept swinging. I don't wanna get hit by you. Okay, so there's a few different ways you can find a vein. Generally your most reliable, easiest way to do it is using these right here, fingers. Even if you can't see them, sometimes you can see veins on somebody like me. I'm just a shade touch off translucent. You can see most of mine. But you get somebody, especially like those with tattoos, and it's gonna be hard to see them. So you gotta be able to generally kind of know your anatomy fairly well, know where your veins are for the most part. And these pictures, all the things in the textbooks, those are guidelines.
Mhm,
People are not always built like a picture.
mhm.
But it's all pretty close. So being able to actually feel what you're looking for. And when we get to that, I got stuff out here. We're gonna tie tourniquets onto each other and be able to kind of feel what's going on. If that doesn't work, yeah, sometimes people, especially if their vascular system's just not great. It could be from overuse of medications, drug abuse. There could just be lots of adipose tissue. You just can't find it, or they have edema, lots of swelling, lots of reasons you're not gonna be able to physically touch or see them. We have a few other little tools we can use. One being an ultrasound, and also a vein finder. Those both take a little bit extra special training, especially the ultrasound. I'll show you some pictures here of what those look like. So this green guy here, this is a vein finder, and how this works, it's a special light that picks up on the iron in your blood and it illuminates it. So it tells you where the veins are, but the downside to it, you have no idea on depth. So if you can't feel it, it's kind of like, okay, well, I know it's there. I hope you get in without going right through the guy. It's a useful tool, not the best, but in a pinch, it can work. Now, the other one over here, my favorite, I wanted to bring one, but my hospital wouldn't let me bring a $30,000 piece of equipment. I don't know why. Is the ultrasound. So this can be done. It's just like any other ultrasound you've seen. Throw a little gel on there, get your little probe, fill around. You can actually visualize what you're looking at. When we use this for veins, so my vascular surgeons, they'll use it to access femoral arteries.
Mhm.
It's great. You can get down, most people's femoral arteries like dead center of their leg. So you can get down pretty far. So kind of what you're looking for is all this mess of gray and black and white. You're looking for this right here. This nice black circle, that's going to be a vein. However, there's other things, the other half of your vascular system running through there, which also, if you just look at it, looks the same, or arteries. Don't poke those. If you feel it bouncing, don't poke it, please. That's bad.
Well, why not?
Because it just keeps bleeding and it doesn't stop. And the doctors generally get very upset when you stab an artery. So the cool thing with these are, it doesn't quite show it the best in this picture, is when you find your vein, all you do is just press down with your probe. And if you see it all the way collapse down, that's a vein, cool. If it doesn't, if it stays taut and rigid, and you can just see it also pulsating, you don't poke that. So what it's showing here, this is just going to be your generalized basic cross-section view. Over here is a transverse. I've seen this done once, and it was one of the coolest things I ever saw. So doc, he comes in, you can actually see the tip of your needle when this comes in. It's a big bright dot. Comes in, then he switched it over once he saw it go in, and then down here, so you're looking at the vein in like cross section. That's your needle right there. And he can follow the catheter, just watch it go all the way up inside that guy.
And I actually do like this method because we have 3 children. Yeah, we're not busy at all, guys. And when I was in labor with our 3rd one, I had, just for some reason, my veins, they rolled. Okay, so I was a very hard stick during labor, and they stuck me 5 times. you're already going through child labor and then you're getting sick. I'm getting pretty annoyed. So then my wonderful husband here is like, let's just do an ultrasound. And I mean, just so quick. And it was actually pretty cool seeing them do that. But of course, with me being impatient, I'm like, let's go. Got to bring a human being into the world. Let's go. You know, so this was I do like this method better.
Well, real quick, getting back to the ultrasound, I said that it takes extra training. Because it's unless you know what you're doing, where to look for, it's easy. You can just flat out miss. You're going to start digging. You'll just pop right through it.
And you have blown veins and
Mhm.
bruising.
It's a good tool if you're trained for it.
Yeah.
All right, that's all the really advanced stuff. Back to kind of what we're focusing on today was just basic IV insertion, right? So we have lots of different sizes. So you have your installing gauges, and the larger the number, the smaller the gauge. So the smaller the diameter of your needle in your catheter. Just give it a size bit here, Penny. Yeah. So you have your two smaller ones, 24, 22, 24 pediatrics, kids, babies. 22 larger children, very smaller adults. Generally, hospital saying you want to stay away from those if you can, just because it's anything you put through there, it's very small. It's going to go through slow, high chance of irritating that vascular tissue. Then you get your two most common sizes here, like you see in the hospital. So you have your 20 gauge and your 18. So ER, we want these guys because these can take everything, blood, any type of medication you need to. Then you get to the harpoons. So if you're 16 to 14, unfortunately, I wasn't able to find one of these to bring today, but I did bring a 16. So 16s, those are gonna be anesthesia. They like to have those in, or trauma. Bit bigger, you can run things faster if you need to, especially bigger bore. Fluids can go a lot faster. Blood, God willing, if you need it, it's gonna be able to go a lot faster. And then there's that thing. You only want to use that guy if you know somebody's like actually bleeding out, because it hurts, it's large, and they're gonna feel a lot. But the point of these 14s here, there is a special machine called a rapid transfuser. It's gonna hammer about a unit of blood, just about 300 milliliters in about 2 minutes. And if you have anything smaller than that, it's just flat out not gonna work. So this is your, oh crap, they need to live button right there. So basic insertion sites, most of the time, we're going to be using somebody's arm. Now, in nursing school, they teach you start at the wrist and work your way up. Okay, yeah, that's fine, because generally, if you start a little bit higher up and you blow the vein, it ruptures, doesn't want to work, well, this is all connected. So if you start down ahead, then go down here, and it's connected to the one you just ruined, and it's not going to do anything for you, right? But in the ER, we just throw all that out the window and just go right for the AC or anticuticle. And we call the anticuticle is just this area here. Yeah, we'll hit the median, cubital vein, basilic, all that good stuff. We like this spot here because generally there's not a lot of tissue that's going to be in the way. Those veins are usually larger. They're generally very superficial. Easy to get into. They can take the large bore needles. You can get the big 14s in those guys too. There's also, aside from the arm, if you can see it, you can stick it. I mean, I've put them in feet, legs, shoulders, chests, breasts, neck. Yeah, if you need a vein or if you need a line on somebody, you need it now. It doesn't really matter where it is. One of the my favorite, but probably the most challenging spot is going to be your external jugular. As you can see on people, you don't need an ultrasound for it. It's a great big monstrous vein. It's really hard to blow because it is so big. However, they don't let outside of the ER. They don't like nurses poking that guy, because if you get in too low, there's a really high risk. If you go right through that, you go right in the chest cavity, cause flash pulmonary edema. Your lungs start filling up with fluid, and that's not really good. You don't want water in your lung cavities. But once you do get it, it's super satisfying. And it can be used for any type of medication, blood, all of it. It's great access to have. All right. So now we're going to pause just me rambling on and start doing little hands-on stuff. So about how many people you said we had?
Quite a few of them.
Yeah,
Well, you only have one.
well, I got one arm, but I have a bunch of stuff here.
Demonstration first.
Yeah, we'll do that.
4 or 5 or something.
Yeah.
So we brought this guy here. If anybody who'd want to try, okay, you guys can actually put an IV in this arm here. That's what it's for. You'll have a lot of this when you go into, you know, nursing school or whatever field you want to go to in the medical field. It's good to have these. But I think right now, he's going to demonstrate on me. Remember, you go home with me later, so.
No pressure.
And it's fine. So. Go ahead.
All right, so generally what you need for put an IV in somebody, first thing, you need an IV. And because I want to make it from one piece, I'm gonna use the smallest one I got. Also, flush. This is called a clave, and then a wonderful IV start kit. What's that?
I'm gonna lower the camera down a little bit.
Sure.
And just a little,
First time with
You know.
you.
make sure your hands are clean, you wear gloves. Okay, we didn't bring that, all right, so. But this is just gonna be like the generic steps for you to find the vein, how to put a tourniquet on. So we're happy to show you that.
First time an intro to healthcare, any I can think of, this is
Oh, okay.
probably the first time in biology, outside of the animal.
Yeah, trash can.
Yeah.
Something.
Do we need anything to prop up the arm, or you wanna do it, have her sit down?
I was gonna sit here, but I didn't know for the
Yeah,
camera.
move the camera.
Okay. So hook flush up onto this guy, flush a little fluid through. Squirt a little bit out of the syringe so that I can actually do a little bit of a blood draw.
You just show out, get your shirt there too.
Okay.
So I'm sure some of you guys have, I mean, or maybe all of you had blood drawn, right? Typical areas here, right? Have you guys had it on the wrist, on the
I
hand?
had it in my hand.
Yeah.
Cause I have that.
We need volunteer for the next one,
Wow.
I'm gonna do it.
And it's very, very, they're not all in there.
So you got it from the peak unit or you were done?
Yeah,
Okay.
they
So there-
couldn't get, they blew both my heels.
Extra credit.
So there is.
Why-
You don't need that. There is actually a contraindication or a reason why you don't ever poke somebody in the foot. Without that. Because it's your blood circulation, especially in the feet, extremities like that, you make a wound. And like heal up too nice. So, our lovely tourniquet here. Generally, the rule of thumb with these guys is high and as tight as you can. Best part is, for the sake of your patient, put it around a cloth, whether it's a gown, shirt, whatever, so. I feel like getting pinched on the back of the arm, right? Right? Also, make sure it's flat. Bring it
Oh,
up,
yes, make sure it's flat, because then it just pinches back there and your patient is basically uncomfortable. They're gonna be uncomfortable here and then they're uncomfortable back here, so.
so I'm holding this end, bringing this is my Titan part here. And all it does is flip through. And I stop, I don't pull it all the way through, I don't put an actual knot in there.
Why not?
There we
Why
have
would you
it.
put a knot there?
Easy to.
Yeah,
To release it, right?
Yeah.
Okay.
you gotta get it off real quick all of a sudden, or if God forbid, I start doing this and. Oh no, this patient got a Hall's coating, I gotta run help, she's not sitting here with a freaking tourniquet on her arm for God knows how long.
We got really awesome like experts about to go. Like, they're gonna go. This is,
So. For her, and the longer you let the tourniquet sit, the more it's gonna do its job. So what's the point of the tourniquet? What's it doing? For this whole procedure? What's that? Pressure, yeah. So what does the pressure do to that vascular system?
Stops the blood flow.
Right. Especially where venous stasis. There's no blood flow going back in. So you're pooling blood in those veins, making them bigger, easier to find, right?
so next step, touching, right? He's feeling for my veins.
Actually, even if you take your patient by the hand here, and even just rotating, that can bring the veins up to the center, go down. I saw us laughing, dude. That's just being spirited. I say, I even have CRNAs that do that. Like, why do you beating the recommendation, man. It doesn't do anything. Like, sure, if you want, that's been disproven a long time ago.
Does anyone like, don't like needles?
Yeah. if anybody-
Yeah, anybody like,
Yeah.
a burst of blood,
Yeah, so we can.
you're gonna pass out, right?
Oh, well, as long as you don't put me.
Yeah.
So-
That's still faint-ish.
Yes. Yeah, if anyone's feeling comfortable.
Watch it.
No, I don't. Maybe. I told you before. But I.
So one thing, if you're not feeling one super quick, you can have your patient flex, and that'll help actually, again, pull that blood where it needs to be. What I'm feeling for right now is what we call the bounce. It's just a very spongy type sensation. Actually, that arm over there, it's pretty good replica of what that actually is supposed to feel like. So as you can see here, for her, she's got some veins right there. 3-finger width on the wrist, no fly zone. Do not poke there. Why? What's in this specific area right here that you don't want to accidentally hit? Yeah. You don't even know which one? Like this one here. What's this one?
It's kind of like, it's gonna survive.
I'm sorry?
It's gonna survive.
Yeah. What artery? You have 2 main arteries that run and feed your hand. One here, one there. Here's a hint. They're named after the bones that are right there. Yeah, you have the radial artery running off your thumb, ulnar artery, come over here off your pinky, come together up here from the palmar arch. Don't poke those. They bleed real bad. Even though they're relatively small, they still make a huge mess. In fact, we're in the cath lab. That is one of our primary points of access, is that radial artery. And yeah, it can make a big mess real quick. A couple things in the kit. There's gauze, tape. This is a tegaderm. This is to help secure your line down once you got it. Alcohol pad. I think I found a good one on her so she won't hit me too hard if I miss.
Why should we always clean the area before we, stick anybody? There you go.
Even bears ain't like this, huh? There's also one other structure right here in the center of that AC area. Tell you guys about. It's a tendon. It's very obvious to tell it's a tendon. It's like a brick. Don't poke that either. Nice big spot to clean. So whenever they initially are teaching you how to poke somebody, they say always do it at a 45-degree angle. If you're an instructor, that's how they tell you to do it. Okay, fine. But in real life, yeah, don't do that. As soon as you get in, you're going to go right through that thing. So generally, like especially for superficial veins like this, I'm going to come in incredibly shallow. I'm going to have the barrel of my catheter almost flush. So, and we'll have some more for you guys to check out. You'll have the bevel of your needle, which is the part where it's cut. Always have that facing up, otherwise it hurts real bad. Don't do that to your patient, especially if it's your wife. Great. You good? So. Okay, now if you guys can see in the barrel, this is filling up with blood, right? It's called a flash. That's what you want to see. So slide that forward. Hold pressure on that vein. Slide that guy underneath. Right now, that needle, it technically is still in her arm. And no, it's not.
And we will sanitize this, I promise.
Then you connect your clave, pull that taut, drop. Off. Just let your arm breathe. Drop back.
If you guys ever, have this opportunity to go in the field and you discouraged because you blew a vein, you can't get it. Guys, you're never probably not gonna get it the first like 10, 20 times. It takes practice. Okay.
And you're gonna have bad days.
You're gonna have bad days. That's when you kind of just tag yourself out and you have your coworker help you out or everything. And that was like the one thing I liked being a medical scribe. I got to see the good, the bad, the indifferent of all sorts of different professionals who maybe couldn't. You need me to do that?
Nope.
Couldn't do IVs, couldn't do certain things that they, because they were just having a rough day, because a patient passed away, so it messes with their mental state, so they have their coworker help them out. So it's all like a teamwork, So like right now, he is,
Securing that line down, so we drew blood, make sure you got good blood draw, flush it back through, don't leave blood sitting in your line. Does anybody have an idea why that's not a good thing? And then, I think you work so hard to put in, that your patients suffer through. It's working.
never do it.
Mhm.
And I don't wanna redo this, so, good job.
I'm writing it all, so normally I throw another piece of tape over here. But the less pain inflicted upon her is better for me. For many obvious reasons.
But you wanna also like show them probably how to tape it correctly. I've seen IVs done like where this part is dangling, and you wanna make sure it's not, cause like if the patient's moving around, they can get caught, and sometimes that can be pulled out, so, okay?
This part here.
Here's the funny thing, I didn't wanna go to nursing school because I don't like needles, but I've had 3 kids, so my mind's changed.
All I do is secure it down like that. Now you're functioning IV.
There you go. Alright, so. When it comes, yeah,
I'll take that out.
so when we are done with the needles, where do you think the needles go? Do we just throw them in the regular trash can?
The shovels.
Yes, why? Is there anyone in here who's going to pursue nursing
Or
or
medicine. in general.
medicine in general?
There you go. Hey, that counts.
That counts. Nice. What about you? What do you wanna? Research.
Cool.
That's cool.
So when you remove an IV, I tell you, get all the sticky stuff off, right? Put your gauze right on top, start initially holding pressure. It's a nice, smooth motion. Check this thing out, make sure it's not broken, it's not super kinked, because one of the issues you can have with these, especially when going into the AC here, people bend their arms, they're moving around, these things will kink off, or they've even made like a Z shapes with, lots of stuff can happen with it.
And I can get a sharp box for that.
Sure.
Okay.
One of the things that can happen, especially when you're taking one out, it's not secured down properly, or maybe it's on blood thinners, or they're just naturally thin blooded, different bleeding disorders that can occur. It's gonna keep going. It's gonna start losing out some more. Very full pressure, super easy. Reinforce your dressing. It's this dressing super saturated. Take it off. Real easy fix. Also, think that makes people freak out the most. I can't tell you how many times we've discharged people from the ER, and immediately come right back out, and there's just a trail of blood flowing.
Anybody have any questions so far before we start? If anybody wants to practice or anything, I'm just gonna go into
That's
questions.
not practice stabbing each other.
Not each other, no, the dummies. Does anybody have any questions or anything? Yes,
Yeah, so you talked about intraosseous. You said it's very painful. So I was asking, is it possible when you are going to use this method, you use anesthesia because it's really, really painful?
So good, yeah. Most of the time, I say like probably a couple dozen I've done, all but maybe 2. They were arresting. They're unconscious. They have no idea what's going on anyway. For the 2 poor souls that were awake, pain was secondary to keeping them alive. And the funny thing about pain, that guy I was telling you about who was bleeding out, low blood volume. Let me see, let me throw this. Thank you. Blood pressure up. So it did end up helping him a little bit to go through a little bit of pain.
If they're like in that state where they're, life or death, would putting them under anesthesia kind of,
Yeah, it's kind of counterintuitive.
yeah.
I mean, they'll be getting lots of medication, keep heart rate up, blood pressure up, all that stuff. I mean,
And also, it depends on the case, person by person, right? Because I mean, what if the patient's DNR? Like, what's DNR? Yeah, so it really just depends the situation on whether you can keep that patient comfortable or not. I mean, I think in a perfect world, we would love to be out first, right, before we have any of that. But it really just depends. Am I using the right stuff? Is
Yeah.
that for cleaning? Disinfect, yeah. All right, and then what's next?
all right, so we got troubleshooting. What do you do if it doesn't go according to plan? So the first one, like the easiest one's gonna happen is no flash, you don't get blood return. Kind of coincides with, oh no, I missed. You kind of got, unfortunately for the patient, you have to dig, so you have to maneuver your needle around a little bit more. That's what's gonna do it to you, because I like life.
Right, so my veins they roll. So that's why he didn't, thank you, by the way.
Yep.
That's why he didn't proceed with this area. So rolling veins is definitely an issue.
Do you know what that actually, what does that mean?
Oh, yeah.
What is rolling veins?
So like you try to reset the video and it's like sliding.
Right,
My veins hide, basically.
or the, just flat out dodge. Like,
Yeah,
veins move, like you go to stick and they'll just melt, they don't wanna be. So a couple ways you can get around that is you can, especially with the elderly population, they'll have very loose skin, grab underneath. Pull the skin taut, use their skin to help stabilize that vein, make sure it doesn't go anywhere. Also pulling traction in this direction is another option. Call for help, and one person, one set of hands, good. And it's the same thing with, you miss, or the veins rolling, you miss, no flash, all kind of goes together. It's just feeling around, feeling where your needle's at, feeling where their vein is, making those minute adjustments. They don't always feel minute, but they are. Just make sure you're getting in the right true limit of that vein, right down the middle there. Another issue you can have is no blood drawbacks. So, I mean, you can tell you're in, you got a little bit of flash, but there's no blood coming out. Why? So, veins take blood where? What?
The heart.
Yeah, okay. Do they have, is there a lot of pressure behind them like arteries?
No,
Okay, what's in the veins to help prevent backflow?
was.
Right, so you can tell, sometimes you're gonna hit a valve. Sometimes you're just not gonna know it. You sometimes on some people you can see them, when the veins like really knobby, those knobs, those are valves. I always think of it as like saloon doors, they open one way. Go ahead and then shut. So you can hit valves, so what you do with that, and you can tell because you're not getting blood out because those valves are snapping shut, right? But you can flush through, there's no problem. So all you do, you take your catheter, it's in the arm right there, just pull it back just a hair, see if you get a little bit of blood, no, pull it back just a little bit more, no, okay, fine. And sometimes even when you get the IV in, you'll get a little flash, you're going to advance your catheter off of that needle, hit a wall, crap, what do you do? Same thing, still a valve, all you do is a nice little trick, it's called a flush push. You just slowly push that flush syringe and slide that bad boy in right at the same time. Opens up those doors and lets your catheter pass right through. The only other issue with valves is if you hit one, it's a higher rate of blowing the vein. So the vein perforates. That's not good. We'll talk about that here in a minute. A couple of things are the not flushing, dripping. It's gonna be sometimes IVs are positional. Might have to just place them back a little bit. Again, another valve problem. Or like I said, kinked cannulas. People are moving, they're grooving. Even they're still. Sometimes if you're rolling your patient, you're having to transfer them from their bed to like a CT scan or something. Things can happen. Those catheters get kinked off. Can't use them. I've seen it where they're pulled out just a hair. Maybe the inserting nurse had trouble with the valve, and then they just start doing this. Well, that's not good. In that case, take them out, put a new one in. And then they got the actual complications. So the two biggest ones are called infiltration and extravasation. They're effectively the same thing. The vein is blown, there's a perforation. The difference is what caused it, what was going in through that catheter when that happened. So infiltration is for a non-vesicant substance. Do you know what a vesicant substance is at all? It's okay, you don't. So a vesicant substance is something that causes irritation and blistering to vascular tissue. So a good example of that, I put up there, potassium. Potassium drips, very, very harsh on your veins. You run them too fast, even some antibiotics as well. You run them too fast, you're going to start causing phlebitis, reddening, rash, slow them down, slow the rate down, they go away. Infiltration, it's a non-vesicant substance. Saline, normal saline, NS. You know, if it's not causing an issue, that's generally not as big a deal as an extravasation because the body's just going to absorb whatever's there anyway. Take it out, stop it, take the line out, put some ice on it, it'll be fine. Extravasation, depending on what's going in, kind of dictates how you're going to treat that complication. Generally, you're going to call farmers and say, hey, this is going in. Most of the time, you'll stop the drip, take the line out, throw ice on it. I think unless it's chemo, I have a lot of experience with chemo, but chemo stuff, drugs, if that leaks out, that's bad news. So yeah, perforation, same thing. If you're going in, you pop through the vessel, walk from the IV in, you blew the vein, you're gonna see it real fast, because if you don't initially see just a bruise forming, which is blood just forming under the skin, you go to flush that IV through and you will see the whole thing just kind of bubble up like bubble wrap. All right, well, take it out, really secure dressing on there, because then you're gonna have lots of bleeding after the extraction, especially if they're on thinners of any kind or blood thinners. And what you do with that is just hold pressure on it, probably about 5 minutes. If it's real bad, really reinforce that dressing, keep an eye on them for a little bit. If they're good, hey, move on. And all right, that's pretty much the end of the show slides there. Does anybody have any questions at all about anything?
Could be anything with our experiences and could
Yeah.
be about our presentation. So yeah. it could
Yeah,
be really
healthcare in
anything.
general.
Yeah.
Or you guys-
I will add, I am college student right now, mom of 3. It's busy. So like so if you guys have any questions on like, I'm just balancing that because it's hard. It really is hard. Like pick our brains, try to give you some good tips and stuff. And with his experience, I mean, I don't know if you said this but he was a travel nurse during the pandemic. That was hard. He has seen and done a lot of things. And then basically the prequel and sequel of COVID, lots of changes in the medical field for sure. So, is there any questions?
Yeah, feel free. Or do you guys just want to start poking things? Yeah, go ahead.
Can you get in trouble for like not getting the vein to someone? Like they can't do anything about it?
Like, so if I'm sitting there like I'm going, I keep missing left and right.
Yeah.
So most nurses, most good nurses have a 2-strike rule. And if you don't get in 2, go get help, go get somebody. You're not gonna get in trouble like officially. A lot of, especially ER nurses, we pride ourselves on being able to get it in one shot. But like I said, sometimes you just have bad days. Like I've trained nursing students, med students, fire, cops, and EMS, everybody on how to do these things. And I've done thousands of them. There's some days I can't hit the broadside of a damn barn. It's just not gonna happen. At that point, there is absolutely no shame going, hey, somebody else come here and take a look at this guy. I got nothing.
And that's okay too. I mean, not necessarily gonna get in trouble by like, you know, who you're working for or anything, but you also have to think about bedside manner, right? How much can your patient take, right? Even if they're maybe like in the ICU floor, they're out and intubated or anything, it's just still, if you can't get it, go ask for help. It's just kind of like that care. Like, how would you want to be treated if you're in that same situation, right?
Or if it's your loved one there, you don't see him just get stabbed by the same person 8 times. It's like when she was talking about had our 3rd daughter. I mean, 4 times by the same person.
Yeah. And they were both like 3 times on this arm, 2 times on this arm. It was just blown veins. And at that point, he wasn't on the clock yet, but I was like, you need to put your nursing hat on and I need you to go find somebody to do this. 'Cause at that point, I was uncomfortable, just trying to bring a 9-pound baby into the world, like, it's no big deal. But yeah, just, that's a good question though, but like, it's okay if you don't get, it takes lots of practice, so.
Just a heads up. So the formal part of intro to health careers is over. You're welcome to stick around for a little bit and learn how to poke. Animal phys, I'd like you to stay for 20 some minutes, since we normally would have a lab at this time, just so you can learn how to do the IVs as part of our lab. And I'm encouraging intro to health careers that is interested to stick around. Otherwise, I understand you got other things going on. But the intro to health careers class is far more being done right now. So if you need to cruise to your next thing, go ahead. And then please, for those that are interested, stick around for another 20 or 30 minutes to see how to poke. And then, or ask more questions. That's not pretty good for at least for animal fit.
Well, thank you guys. I appreciate your time.
Thank you. Yes.
So I want to ask this question.
Thank you.
I've seen a situation before where someone was infused, like instead of the infusion getting into the patient, his blood was rather moving into the infusion. So what would be the reason behind that?
Backflow is what we call it. So, if you have a line sitting in somebody, let's just say there's a saline drip running through it, right? And it's not moving anymore, or the bag has gone empty. It's a simple physics issue of pressure and volume, right? You're gonna have a higher pressure, higher volume in your body. You're gonna have that extra hole there. Fluid mechanics is just gonna eventually slowly push it back out, up that IV tubing or out that catheter, or even up into the medication. Generally, what you do with that is you want to disconnect that entire tubing, throw that bag away. You know if there's blood clots in there or not. Have that IV catheter sitting there, get a saline syringe, squirt some fluid out, draw blood back out, waste some, just keep like 2 or 3 syringes, like 10 ml syringes worth, flush it through. If it's still working okay, yeah, you can use it again, not a big deal. Yeah, usually if there's no forward pressure coming from that line, pushing anything in there, very common, you're gonna have blood just coming right back up out of it.
That's a good question.
When you were presenting, we were looking at ways to locate the veins. And I was thinking about what if you apply heat, like heat to it, is it accepted to apply heat?
It is.
Like a warm towel to dilate the
Yes.
vessels for you.
Yeah, that's a good point. It is absolutely, especially if you have somebody coming in from the cold. Pediatrics, also a good thing. So when we do have to do a heel stick on an infant, we'll have a heel warmer. Kids are a special, like real special consideration. Their hands down be the hardest patient population to get lines on. It takes a lot of practice. And when I traveled, I worked at a pediatric ER and still hate it to this day. But there's definitely ways you can go about it, helping with kids. But yeah, heat is definitely a good thing to utilize.
Especially for newborns, because newborns, they would have to heat up the heel for their heels to get check their bilirubin. So yeah, that is one way, and it's easier to get blood that way too. You don't want to see your little one do that, but yeah.
What about heating? Because I've had some phlebotomy experience. Sometimes we heat the patient's vein just to allow it to palpate so that we can see it well. Is it wrong?
It's not wrong. I don't think it's wrong. I don't generally utilize that in my practice. I mean, if it works, I've seen people use it, they swear by it. I've seen a lot of old school nurses be like, this is the way you gotta do it. No, you don't. It's personal preference. I mean, if for whatever reason, if it seems to work better for you, sure. If not, like I said, I don't use it, but if that works for you, man, hey, go for it.
Okay.
Yeah, sure. Any other questions?
You're not able to find your brain so deep, or maybe it's difficult just to find. So what should you do?
When it comes to not being able to find anything obvious, nothing superficial, that's when I would probably bust out the ultrasound machine, Cause that, you're gonna be able to find those deeper, larger bore vessels. And that's really your only option at that point. If that's not if you don't have one of those handy, not available, you're not trained on, you know what to do. Looking at other various parts of the body. Like it doesn't have to be in an arm, it's preferred. But sometimes if they need something, they gotta get medicine, you gotta get blood out. Doctor can be happy if you can get one in anywhere.
So why do you think is like that? Some individuals, their brain is so deep, you can't see it. Why is something individuals like that?
The short, easy answer is people are weird. Like everybody is, you know, like I said, with the textbook picture, that's kind of a general layout. That's a guideline. Not everybody's built that way. I've seen people where they're, even especially even in the arterial system, we'll get radial access in the cath lab. We get up and then all of a sudden they're supposedly straight radial to brachial vein, nice big long tube, right? Does that. You can't get through it, or it'll curlicue like a pigtail. It'll just, for some reason, shrink down. You can't get anything through. I've seen people whose iliac arteries are literally crossed over each other. People are just built strange.
And
Everybody's
also,
built the same.
and sorry to interrupt, but it also depends on the history of the patient. Okay, I've seen patients before they come in, they were, drug addicts and everything. And so when they would shoot, like they blow their own veins because they typically are the ones doing that to themselves. And when they come in for like emergencies or anything, it's hard to really find that vein. So like I said, it really just depends on that individual too.
And piggybacking off of that, you can also have sclerosis in the veins. You can have scar tissue, like people who are chronically sick, have a lot of issues. They are always needing IVs. You're going to create lots of scar tissue. It's going to really reduce the amount of spots you can get on somebody. I told you when I was putting the IV in her that you don't want to poke in that wrist, right? There's one person that would come in all the time to my ER. That vein's the only one that worked. Because we'd have to run that risk.
Like me,
What's that?
my vein. My vein here, it works like, you can't see any other place, just here.
Mhm.
Wherever I go, whatever it is, you can only get blood from here.
You get that. I've had IVs here and it's painful. And on the hand, I
Yeah,
think
hands
the
hurt.
hand is
Hands hurt.
painful, so painful.
Yeah.
Yeah.
All right, so, when, I don't know, during my practice, when I'm taking drawing blood from this place, in most cases, I see signs of, hematoma. Right? So when this happens, what is the best thing to do? Because what we were told there was massage it, but I don't know, I just want to know with your experience, what do you think is the best?
So for like a venous hematoma versus an arterial, venous pressure. Pressure. You can try to reduce it. If it's growing and growing, it will stop, but just hold direct pressure on that guy. Make sure dressing is nice and tight, not tight enough you're going to cut off circulation, but it's very reinforced, very snug. I have seen some leave that to the physicians. They'll try and reduce it and get all that blood out. It's not necessary, in my opinion. Now, a arterial hematoma, yeah, that's bad because that's just not going to stop. I mean, your blood's going to be constantly pumping in through that arteriotomy site. That is lots of pressure for a long time. Because we'll have that some more often than not, like if we're getting radial access in the cath lab, we'll put a special compression device on there that holds pressure on that for about 2 hours. Patients moving around though, yeah, you can still get a hematoma forming. It's just more pressure for longer periods.
Now, is it normal to have it, but it's maybe if you make a mistake in drawing the blood, or it's normal to have a hematoma when blood is drawn on the palm?
If it kind of depending on the situation. So if you're getting that needle in, and as soon as you poke and it just bubbles up and perforates like that, generally that's going to be due to patients like very thin vascular walls. Especially get to the older population, the elderly, sometimes you can just breathe on a vein, and there it goes, popped right open. Nothing you can do about it. That's just how they are. So again, just pressure right through there. Now, the other thing, if, especially someone younger, they also have that thin vascular wall issue, that's probably a you problem. Great, I don't too. You're going through that vessel, you get in and then you pop out the other side.
Mhm.
So it's a through and through.
Or you're going too
Oh.
fast. That was another thing.
Yeah. So, because normally if you're getting into a vest, like a vein with a line or IV, you're not gonna have blood coming around your needle, shouldn't, most of the time, 99% of the time. However, if you get in, it's like, oh yeah, I got stuff, and then all of a sudden it starts going up and your needle's still in there, you've probably popped out that other side, or like gone through the wall in another secondary location, drawn back a little bit, now that's leaking out.
Any more questions? No? Does anybody want to try? Not on me, though. No? I can also bring this over here too.
Or you can just like take these out, pick them out, so that you don't have to go after the dummy. If you're gonna get hands on any of this stuff, I brought extras.
Yeah. Just hands on. There's 12. Andrew's here.
Oh, this is all me now.
That's all I do.
What's your name, man? I'm Bill. Andrew. So. You can use this if you want, obviously. Dude's got pretty good things. So you get the phlebotomy experience, you know, that bounce I'm talking about, that spongy sensation. So you can feel it real good. This is pretty dang close to what it's like in real life. So like mine, right there. Yeah, that, yeah, absolutely. I'll be the test dummy too. So that's that bounce spongy sensation you're looking for. This is just false, so nothing's gonna shoot out. You can just yeah, the hospital didn't let me. We only have the fun. So yeah, there's, if you had one of these, the turkey did a whole shebang, that's cool. I only had one flush and clay. But trinkets in there, cleaning, tegaderm, brought. So these are good, there's different like lengths of IVs as well. So these are 1.25. Yeah, these are 1.25 inch long. This is gonna be your standard operating superficial veins. I brought a couple longer ultrasound needles as well. There's even a third one that goes probably out the back here. Yeah, crack them open. It's all gonna get thrown away. If not, I was able to bring one big 16 gauge, not the big nasty 14s.
Yeah, for each patient, how starting to get over. It's coming to for each patient.
Yeah.
Wow.
Yes.
Well, phlebotomy, you just do all the house, so you got your tourniquets for the
Yeah.
phlebotomy. Yeah, that makes sense.
Really good.
Thank you for the video. Thank you so much for coming out.
Pleasure.
And it was.
An incredible presentation.
Thank you, I appreciate it.
I'm really, you should think about being a teacher.
Yeah, I should
You should.
up my case about that.
You know, you could be a nurse professor or something.
You gotta have.
Yeah.
You do?
Yeah, I thought you knew about that. Yeah.
No.
So WIU has a program. If you're interested in nursing, you definitely should apply. There's an RN to BSN and there is also a true BSN program from scratch.